Thank you, Dr. Haas, for the invitation, and to all of you for sticking around to listen, and to Mr. Nicholson and to the Judy Nicholson Foundation for the invitation and organizing this wonderful conference. It seems like I'm a little bit of an imposter to talk about surgery when I'm not a surgeon, but if you ever saw a pumpkin that I tried to carve, you'd probably say it's good that he stays out of the OR. I'm going to start with a case presentation, and hearing some of the talks today, these type of situations may be familiar. And I should say even maybe even better than a surgeon. Many of you have been through this type of surgery and would be better to give the talk, I think, than me. But I'll take you through what I put together. This is a hypothetical gentleman who underwent a CAT scan after an automobile accident and was found incidentally to have an 8-centimeter kidney tumor. He had no other areas of cancer on his scans, and he had surgery to remove this. And for a number of years, fortunately, his scans looked fine. But then unfortunately, 5 years later, there was a single lung nodule seen on surveillance CAT scan. And he wasn't having any symptoms at all. He was feeling fine. And so what should he do next? What's the best next step in taking care of this gentleman? He could have local therapy, surgery, or radiation, or one of these ablative techniques that you heard about, or he could have, as a broad category, systemic therapy, what people used to refer to as chemotherapy, but for kidney cancer would be either targeted therapy or immunotherapy or something along those lines, a clinical trial. And then observation might be an option. With it being asymptomatic, we don't know when his last scan was. If it's growing slowly, there might be no reason to take a risk right now of a treatment. So when we use this term metastasectomy, what do we mean? We mean surgery to remove a cancer beyond the primary site. And this could be a surgery of the bone, as you heard about from Dr. Wilson, or the lung, or the thyroid, or the brain, or the pancreas, pretty much any part in the body. If you think it's helpful, you could consider referring to a surgeon. And this could be done at the time of the primary surgery for the kidney tumor, or years later. Why would we consider surgery? To alleviate or prevent local symptoms, and that's also, you heard an excellent description of where this is so important by Dr. Wilson in terms of the weight-bearing bones and the skeleton. And in other cases, like the gentleman I presented, they're not having any symptoms. The metastatic growth may not be itself a threat anytime soon, but there's an idea that possibly taking out that tumor will help control the cancer in the big picture. It'll help the patient live longer with a good quality of life. And also in this day and age, especially if it's been a long time since their primary surgery, having some additional tissue may be helpful in us being smarter about using systemic therapy by seeing if there have been any changes in the molecular features of the cancer. So in terms of cancer control, surgery may allow you to avoid systemic treatment, possibly for years, and the potential toxicities of systemic therapy, which we heard about, or if combined with systemic therapy, may allow may delay the development of resistant clones, and you heard about this earlier in the conference, that how genetically diverse the cancers are, and that they mutate to become resistant to our therapies by natural selection. And it may be, in simplistic terms, if the cancer has fewer lottery tickets to begin with, if you can reduce that by a factor of 100 or a factor of 1,000 by taking out all the visible tumor, it may take substantially longer for them to get that one lottery ticket where they have a mutation that allows the tumor to escape our therapy. So knowing that there are these arguments in favor of surgery, how it could be helpful, should we do it? And to put it simply, do the risks of subjecting the patient to an operation outweigh the potential benefits? And this is a question we've been wrestling with for a long time. Even Hippocrates observed the different stages of cancer, one of the earliest people to do so, and advised against surgery for advanced disease. I think the surgery's got a little better since 400 BC, so maybe that's not fair, but this is a question at least that people have been wrestling with. And I think the counter argument to doing surgery is that, and that's sort of been a dogma, is that once a cancer has been detected outside the primary site, that it's a systemic process, that the cells are in other areas of the body, microscopically we can't see, and it's kind of like closing the barn door after the horse has bolted to do surgery and take out the areas that we can see because there are other areas that we can't see. And so how do we know whether surgery could be beneficial or not? What's the data that we rely upon? We've heard a lot about clinical trials. We've heard some of the potential benefits of randomized trials and some of the drawbacks, and we think of them as the gold standard. Do we have any clinical trials of metastasectomy versus no metastasectomy? And the answer is no, we don't. It's never been done. And so how do we make these recommendations to our patients? We rely on the personal experience of the patients and the physicians and people in the field, and published retrospective series, and do our best with the data that we have. And it's not so much a question, should we do it, yes or no, across the board, but who might benefit from surgery? Not all patients, of course, are the same. Not every situation is the same. And how can we tell who might benefit most? People have tried to answer this question over the years, again, in the absence of a randomized trial, looking back at the series of patients that they treated at their hospital or collection of hospitals retrospectively. And to summarize dozens of papers over the past 50 years, it appears that the number of metastatic sites is predictive of having a long period of cancer control after surgery. If there's just one site or a couple of sites, it's less likely that that's the tip of the iceberg we can't see than if there's 10 or 20 sites. And also the disease-free interval. If somebody had a nephrectomy 5 years ago and now they have a single lung nodule, it's more likely, based on these retrospective series, that they're going to get longer mileage out of another surgery than if it's at the same time that the primary cancer presented or not long afterwards. And again, to summarize a lot of thinking and some data on this, we don't, unfortunately, really have a set formula or highly evidence-based approach to make a recommendation whether a person should have a metastasectomy or not. And there's some people where it's obvious surgery would be harmful to them because of their overall condition or risks of going through surgery. But for many people, we really don't have data to guide us, and we wrestle with it, relying on our own experience. And importantly, the patient's own preference comes into this as maybe the most important factor when we factor everything into account. So back to our case presentation, the patient elects to undergo surgery for this lung nodule, and now after surgery, he has clear scans. It's good news. He has no evidence of disease at this point. And his medical oncologist recommends close follow-up at this point, no systemic therapy. And to put that in perspective, all of the clinical trials that you've heard about examining the VEGF receptor targeted drugs like sunitinib, Pazopanib, and the immune therapies, all of those trials, you had to have some measurable or at least evaluable disease on your scan, something that was there to follow to be in those studies. And all the data showing that those drugs are helpful are in the setting of patients who have a kind of a bulk amount of disease, at least enough to see on scans reliably. And we don't really know if patients with possibly only microscopic disease are going to get the same benefit from any particular therapy. And one of our principles in medicine, again back to Hippocrates, is first do no harm. And if we don't have evidence that a medicine is helpful to a particular patient and we know it has serious side effects, we often err on the side of first do no harm. So that's, as medical oncologists, and where we're coming from. And this is actually taken from a true case. The surgeon was furious that no systemic therapy was offered to the patient after he or she went to the whole process of doing the surgery and working with the patient going through the operative process. And the logic there was the risk of recurrence is high, so even if we don't have strong evidence that adding a medicine now should be helpful, we know the cancer is bad, we should kind of throw the kitchen sink at it. And that's the counter argument. And that's what I call the metastasectomy dilemma, because we wrestle with this when we see patients in the clinic who've undergone surgery. Now they have negative scans, and it's something that I think we've been wrestling with for a long time, since we started to have systemic therapies. The dilemma is that the risk of recurrence is high after metastasectomy. We know from these retrospective series it's considerably higher than even the high-risk patients who've undergone nephrectomy for localized disease. And as I mentioned, we don't yet have systemic therapy that's shown to be helpful in this specific setting. So that's the dilemma, and that's where there has been a real unmet need in the field to give patients an informed recommendation of what to do after surgery. And in the last decade, there were two randomized clinical trials that sought to address the question. The one that was presented first in the 2018 ASCO was from Dr. Procopio and his colleagues in Milan, where they randomized patients to receive a year of sorafenib treatment or observation after metastasectomy. Here's the design of their trial, and they showed that there was no benefit to sorafenib in terms of the risk of the cancer coming back, what they called recurrence-free survival. And similarly, in our ECOG Akron cooperative group, we designed a study, similar design using another VEGF receptor TKI called Pazopanib. And in our study, this was the design. Patients were stratified by those two factors that we thought, I mentioned earlier, affect the risk, help predict the risk of the cancer coming back, and then received either Pazopanib or a placebo pill for a year. Patients had scans every 3 months, and we looked at what we call disease-free survival, the chance of them having, whether the cancer came back or not, also overall survival, and you'll see there patient-reported outcomes, which you heard about from Dr. Wagner earlier this afternoon, and laboratory correlates. So that was the design of the study, and here's our result. Like the sorafenib study, we found that there was no benefit to Pazopanib versus placebo for a year in these patients. And we were disappointed that the study treatment didn't help patients. What it does allow us to do now, and we owe this entirely to the generosity and the bravery of the volunteers who participated in the study, is now when we're sitting with the patient in the office and they've had a surgery and we're talking with them about what to do next, we can say with some confidence, we know that you're not shortchanging yourself by not going on one of these oral TKIs, at least the two that were studied in this setting. We know, based on randomized data, high quality data, that it's not going to help you, and you can feel comfortable doing observation in that setting. The other thing that I think we learned from this study was having a multi-center prospective group of patients, 129 patients who underwent metastasectomy and then were followed. And there's a number of potential biases in looking at collections of patients retrospectively and looking at a single center, especially if it's a referral center where people have to travel a large distance and are going to be the fittest patients. Many of the patients were accrued at community centers, and what we can say is that the risk of the cancer coming back was at 3 years about 75%, which is actually about what we predicted when we designed the study. And that's something we can share with patients who are thinking about undergoing surgery, that in the absence of an effective systemic therapy, that there's about a 75% chance the cancer will come back within 3 years. And the other thing to notice is that there's a little tail of the curve, and you heard from Dr. Porta talking about the tail of the curve in his talk, and that we're hoping to, with immunotherapy and other modalities, to extend the tail of the curve, those patients who have a longer disease-free survival or overall survival. And we'll have more information as we follow these patients longer, but hopefully this may turn out to be the case, that just by having surgery, there's a select population of patients who have a longer survival. And I would encourage you to look up online this article by Stephen Jay Gould, who is a biologist at Harvard, evolutionary biologist, but he was diagnosed with a very rare cancer, peritoneal mesothelioma. And he talks in this article about going to the Countway Science Library and reading about the statistics, and he read about the median survival, just as we talked about the median survival after diagnosis with bone metastasis. It's a frightening number, and the median survival for patients with peritoneal mesothelioma was really frightening, that he read in the 80s especially. And what he took away from the curves was that there was a tail of the curve of patients who lived longer, and he ended up being on the tail of the curve and living for another 20 years, and he passed away from an unrelated cancer. So the median isn't the message, and I think the tail of the curve is where we're putting a lot of our effort, and hopefully our therapies, whether it's surgery or systemic therapy, will shift up the tail of the curve to include more and more patients. In the ECOG-Akron study, we found that disease-free interval did appear to predict for risk of the cancer coming back after surgery. For the number of metastatic sites in our study did not predict strongly the risk of recurrence, although the number of patients with multiple sites was relatively low. I'm going to talk a little bit about cytoreductive nephrectomy because that's a related topic, and this is a treatment that has been in use for many decades, and like metastasectomy, for a long time we didn't really have good data on whether it was helpful or not. In the 90s and early 2000s, there were two studies that were randomized prospective clinical trials comparing cytoreductive nephrectomy to systemic therapy alone, and in those days, the systemic therapy was interferon alpha, which we generally don't use anymore, and they found an overall survival advantage to the surgery versus interferon alone in these two studies independently when you combine the data together. But we're in a different era now. We're no longer in the era of interferon. We're now, at least in the past decade, we're in the era of all the targeted agents, and if you change the systemic therapy, you may change the contribution that the surgery has to the overall treatment plan. And to their great, well, I'll show first a retrospective series that was put together to address this question from Dr. Heng and the IMDC group. And looking retrospectively, they found that patients who had intermediate risk of advanced renal cell with 1, 2, or 3 risk factors, among those patients, the ones who had surgery did better than the ones who didn't have surgery, and they did their best to account for all the what we call confounding factors that might have explained that, well, these people didn't have surgery because they had another serious medical problem where they were too sick to undergo surgery, and that's why they didn't live as long. So they did their best to address that, but still you can criticize that data by saying it's retrospective, and you may not be able to account for all the confounding factors, and it may be that we're better in picking patients for surgery than we think we are, and that's why the surgery patients appeared to live longer. To their great credit, the French group, led by a urologist, Dr. Mijan, conducted a randomized study of cytoreductive nephrectomy followed by sunitinib versus sunitinib alone, again in the years when this was the standard of care. And just to make a long story and many years of effort by the patients and doctors in the study, to make that a short story, the surgery surgery was not found to be I always get this statistic. The design of the study was whether by overall survival sunitinib alone would be non-inferior to the standard of nephrectomy plus sunitinib, and actually the sunitinib alone group it wasn't statistically significant, but had a slightly lower risk of death, a slightly better survival. And for progression-free survival, it also appeared that the patients who had sunitinib alone fared better than the patients who had nephrectomy followed by sunitinib. And part of this may have been due to the 3 to 6 week delay between having surgery and to starting sunitinib to allow for wound healing. And there were some other factors which he speculated about when he gave his ASCO plenary presentation. So will these results from a randomized trial change practice? And I think that's a complicated question, and Dr. Mijan alluded to this in his ASCO talk, that first slide was he showed a patient who had a very large primary tumor and some small metastasis, and he said, of course, someone like that we're going to take to surgery. It's just common sense. They're going to benefit, and those patients were not included in the trial. So you have to take into account the study is assessing the impact of surgery in patients who were felt by experienced surgeons and medical oncologists they had equipoise, they weren't sure if surgery would be beneficial or not, and you don't know sort of where how they drew the line. And also, now that the immune therapy has entered the first line standard of care, we're kind of back to square one on what is the added contribution of cytoreductive nephrectomy. So there's a lot of controversy around that, and I don't have the answer. I'm just kind of presenting the issue there. So what are some future directions in terms of metastasectomy? As I mentioned, now in the era of the immune checkpoint inhibitors, there are randomized studies in the adjuvant space that are allowing some patients with oligometastatic, just a few sites of metastatic disease, to be enrolled after surgery to remove those metastases. And we'll see those results in a few years when those studies are ready. And Dr. Haas showed you, told you about the Dr. Harshman's study, the Prosper RCC study design where patients receive preoperative nivolumab, have their nephrectomy, and then receive nivolumab versus surgery alone. And this study allows patients with oligometastatic disease at the time of diagnosis, as long as the surgery is done around the same time or at the same time as the primary surgery. So we'll have the results of this study as well to guide us. And you heard from Dr. Wilson's talk about some of the additional local techniques for taking out, for treating tumors, neutralizing them in addition to surgery, traditional surgery. So what might be a future paradigm for patients who have just a few sites of disease, as in the Prosper study, if that ends up being an effective treatment arm, you might see preoperative priming with immunotherapy surgery to remove metastasis, and then postoperative immune therapy. So I think we're not really in a time of medicine versus surgery anymore, but more, for some patients at least, medicine and surgery systemic therapy and surgery can be used together. And that may not apply to all patients, or there might be, for a particular patient, there might be a time when surgery is appropriate and another time when medicine is appropriate. But I think this is a serious disease, and we need to use all the tools we can and study the tools critically to see where they can have the most impact. Thank you all for listening.
Questions for Dr. Appleman? I think in general, one thing that I take from the Carmina trial is that if you have a lot of active disease and you need to get started on treatment, it's probably better to start with the systemic treatment, because often we can tell within a couple of months of treating if your cancer is being really responsive to the treatment. Then there's still an option to go back later and take a big kidney mass out. So, for example, sometimes we have people that come in with a lot of disease, and we start them on treatment and say, this has happened a number of times, their disease shrinks really well on immunotherapy, and then maybe a year later we go back and take the kidney mass out, and they might even be able to stop their treatment at that point, and you didn't know that at the time. There's other people that they come in and they have bad disease and they don't do so well with their treatment, and at least, and then we don't take their kidney out, but at least we know that we're treating them as quickly as possible with treatment that was going to reach everywhere in their body. So the question of immunotherapy versus doing surgery or immunotherapy alone, that's a trial that's been proposed and is being voted on really in the next couple weeks by the Genitourinary NCI Steering Committee. And if they approve that trial, then there'll be another trial going forward that will give immune therapy to one arm, and the other arm, after a little bit of immune therapy, will go on to have cytoreductive nephrectomy. Questions? Cytoreductive is? That means taking the kidney out in the face of having disease in other parts of the body. And the reason to do that, if you have a small kidney mass and you have a lot of other disease, it's not really helpful to take out the kidney tumor. But if you have a really large kidney mass, maybe you get blood in your urine, or you're having pain in that area, or it's sort of the biggest mass, there's some evidence that treating people might do a little bit better if they don't have as much cancer in their body, and so at some point you might want to take out that big mass, and other stuff might keep responding. So that's really the question at hand.
Is that implying that the kidney is, for want of a better word, infecting one more of the body?
Yes, so he asked, why would you take out a large kidney mass? Could it be seeding other areas of the body? And that's exactly one of the principles, but the other principle is that something about the original characteristics of the kidney cancer, the kidney tumor, back when we were doing the interferon studies, the idea was if you took the kidney, there were these two studies that Dr. Appleman showed that were with interferon. And so what people thought, at least, was if you took the kidney tumor out, people did better on those studies. Now, it could be for two reasons. It could be because taking the kidney tumor out really had an immune effect and everybody did better. The other possibility is that interferon was so inactive by itself that taking the kidney out was really the only active therapy, and that's why people did better. But now that we have so much better therapies, it's worth asking those questions again. They're important questions. Yes. Hold on, they can't hear you on the live stream without the microphone, so.
Very narrow question, but does immunosuppression for other conditions rule out immunotherapy?
It depends on the situation. So if you're if you have a transplant, if you have a kidney transplant or a liver transplant, generally if we're using these immune checkpoint inhibitors, it's kind of turning off your your immunosuppressive medicine, and you would reject your organ. So that's if you've had a liver transplant, that's almost not something we can do. If you've had a kidney transplant, then you're making a hard decision about, do you want to lose that kidney and go on dialysis? If you have some, sort of soft things, like if you have psoriasis, some other immune things like that, you might be able to tolerate immune therapy. But if you have a more serious underlying autoimmune disease like rheumatoid arthritis or Crohn's disease or lupus, those can be pretty dangerous things to turn on with these immune checkpoint inhibitors.
Thank you.
Just very simple question, like the lung mets that you talked about. I used to hear there was a limit, like if you have maybe 2 mets, maybe 3, after that, we're not taking them out. Is there kind of a rule?
I think when you think about, is there a rule, I think it's helpful to take a step back and say, are there data to base a rule upon? And I think we have some general data. We know there's a trend that the more sites there are, based on these retrospective series, the more likely it is it's going to come back sooner. And also, I know for my patients who have had lung metastasis, both the number and the location of the metastasis makes a huge difference on what kind of surgery they do, if it's just some limited wedge resections or if they have to take out a whole lobe of the lung. So at some number, you start to worry about lung function, or if you doing too big a radical orthopedic procedure may leave the person disabled. So there's situations where there's just going to be an immediate impact of doing a really big surgery. And in terms of, from an oncologic point of view, do we have high-level evidence that the overall benefit of surgery drops off with a particular number? We don't at all. It's just we're just sort of going on common sense. But I wouldn't say there's really there's no data to support a strict limit.
And Len, I think you showed some examples of, if you're getting like one metastasis every 3 or 4 years, or 2 metastases, and that's all you're getting, and you get 2 or 3, 4 years, then, those are the people that you certainly still want to have under consideration. Do you do another metastatectomy?